Good afternoon, everyone, and welcome to the post-lunch session. And this, within this 45 minutes, we are going to discuss a very important topic in our day-to-day practice, atrial fibrillation. The topic of our presentation is essentials of atrial fibrillation. And to give you an updated and sound understanding of this topic, we have got an eminent speaker today. He's Dr. Rohan Gunawardena. He's the consultant cardio-electrophysiologist at National Hospital, Sri Lanka. And he's going to talk to you much on the practical aspect of the management of atrial fibrillation, and which is very relevant to the physicians who are practicing in this field. So without much ado, I am going to invite Dr. Gunawardena to start his presentation. And first, this is going to be an interactive session, question and answer session. So we are, my first question is, actually, Dr. Rohan, why do we need to talk about this atrial fibrillation? Because we hear a lot of talks going on in everywhere, especially in cardiovascular medicine field. Wherever you go, in every symposium or sessions, you would see this topic coming up. And it has become a very regular topic in most of the cardiology sessions. And is this just a hype, or is there any reason why it is there is so much of interest of this topic?
Thank you, University. Thank you for the introduction. And let me thank the College of Internal Medicine Specialists. That's how it goes, no?
Yes.
For inviting me to give this lecture. I'm particularly pleased because this is one of my favorite topics as well.
All right.
Well, atrial fibrillation, if you think about atrial fibrillation, it's the commonest arrhythmia worldwide, affecting about up to about 1 to 2% of patients below 50 years and going up to about more than 8% when you have patients who are 80 years old. Right? It's a very common thing. While we tend to think that Caucasians are more affected with atrial fibrillation, that may be just something that we think because we haven't really done studies in our part of the world to see the prevalence and the incidence and prevalence. But now studies which have been done by the Asia-Pacific Heart Rhythm Society are also showing up that even in Asia, atrial fibrillation is a significant problem. And if you look at it, it is in fact causes significant mortality and morbidity. And though we have been treating atrial fibrillation for a long, long time, we still don't manage it properly most of the time. Yeah, right. And particularly when it comes to anticoagulation, that's an area where we are kind of bit at fault in the sense that we don't really manage it properly. So I think it's very important to come back to atrial fibrillation once in a while to look at it, particularly in this instance, because the European Society of Cardiology put out their guidelines in 2020. So that's also it's a good time, therefore, to talk about atrial fibrillation.
All right, okay. With that background, I think now, you know that when we talk about atrial fibrillation, there are so many, I mean, we have to get used to the terminology. Yeah. That's the first thing, because it has been changing all the time, and time to time, various kind of terminology, and especially classification comes up. And we are confused because as practicing physicians, we don't have time to read all these things and get updated. And can you please...
Yeah, that's a good point, because we have been saying various things for atrial fibrillation. We have called it lone atrial fibrillation. We have talked about valvular atrial fibrillation, non-valvular atrial fibrillation, chronic atrial fibrillation. But all these terminologies are no longer to be used. And the European Society of Cardiology put out this terminology, which actually, this classification, not that is new, it had been there for some time, but this is what now is going to be accepted. So essentially, you have what you call the first diagnosed AF, which is where the patient is now, the first time that the patient is actually been diagnosed as having atrial fibrillation. So the first time that the patient has actually gone to a clinician and atrial fibrillation has been diagnosed. That does not mean the patient didn't have AF earlier. It just means that this is the first time that we actually caught it. Right? That's the important point. Then we have paroxysmal atrial fibrillation, which is where atrial fibrillation has spontaneously terminated within the first 7 days of onset. Right? If it persists for more than 7 days, it becomes persistent atrial fibrillation. And if it goes on for more than one year, it becomes long-standing persistent. And then you have permanent atrial fibrillation, which is a kind of it's not exactly it's a situation where you have discussed with the patient and decide whether we are going to be in atrial fibrillation or not.
Yeah.
So that's the kind of situation.
Yeah. Can you just elaborate on these last two things? That there's one thing called long-standing persistent AF and the permanent AF. It's just a kind of how you reach.
Yeah. So you can see that if you look at these terminologies, the classification, these can all go into each other. For instance, if you have paroxysmal atrial fibrillation, it can, if it lasts for long enough, it might become persistent.
Yeah.
And similarly, persistent atrial fibrillation can become long-standing persistent. So long-standing persistent atrial fibrillation, where atrial fibrillation is there for more than 1 year, but you might, clinician might decide, okay, let's try and cardiovert the patient to sinuses. Then it might become paroxysmal. Yeah. So in the same way, there might be a time when the patient is in atrial fibrillation for a long time, and then there is no chance of the patient being cardioverted. Yeah. We are not able to achieve sinus rhythm. In that situation, a decision is made together with the patient to say, okay, this is a situation, we can't get you back into sinus rhythm, so therefore we are going to treat you as atrial fibrillation for the rest of your life. Yeah. That it becomes permanent atrial fibrillation. But remember that later on somebody else might say, oh no, this sounds not a good idea, or the patient might become more symptomatic, and then we might have an intervention where we want to change, to try to get sinus rhythm. Then it becomes long-standing. So it's a kind of fluid. Agreement. Yeah, it's a kind of fluid kind of classification.
Right. Okay. Thanks. Now we know that they can present in various ways, and sometimes it's a very subtle way they can present with. Can you just brief us on the various ways they can present?
Okay. So we know that AF can present in various different ways. Very often patients are asymptomatic. So and therefore it's what we call incidental findings. So if you, for instance, if you go to a doctor for something else and the doctor feels the pulse and finds the irregular pulse, they might do ECG and find that patient has atrial fibrillation. Similarly, now a lot of people are doing routine checkups, and even say companies, private companies, or even say army, for instance, they do regular checkups, and in those situations, ECG becomes part of that. And that might also, be able to find out whether there's atrial fibrillation. And sometimes patient might come with a complication like stroke, and then we find that the patient has atrial fibrillation. So sometimes what happens is very often, many patients with atrial fibrillation actually are not symptomatic. So this is one of the problems that we have, right? Of course, you have the symptomatic patients who comes with palpitations, tiredness, shorter of breath, heart failure, angina, and even maybe coming with hemodynamic collapse. In that situation is obvious, it's a kind of presentation where we have symptomatic atrial fibrillation. We also know that certain stressful situations can precipitate atrial fibrillations. So severe physical and mental stress, and if you, for instance, alcohol binger, then substance abuse, particularly cocaine and heroin, if they go on a binge of substance abuse, they can actually get atrial fibrillation. We also know that certain medical and surgical conditions, like for instance, a patient is having, say, sepsis, and very often they go into, and I'm sure that you will have seen in ICUs, patients going into atrial fibrillation with this.
Especially after surgery, we have been called.
Yes, that's a common thing. This particularly cardiac surgery, that happens a lot because surgeons are very happy to kind of play around with the heart and they move it around here and there. So that can cause actually an increase in the incidence of atrial fibrillation.
So it's especially after cardiothoracic surgery.
Yes, very common.
So it's could be. Now you know that the mainstay of diagnosis ECG. But there could be many manifestations in the ECG as well, even though the condition is the same.
Yes, that is true. So now I'll just show you. This is a kind of standard ECG that we see. So we see a irregular, narrow, complete tachycardia. That's a standard kind of atrial fibrillation ECG that we might see, right? But there are other presentations as well. Right? For instance, have a look at this. Now here is a situation you have run of atrial fibrillation and then long pauses. So this is a condition where we call wave 6 sinus syndrome or tachybrady syndrome. In this situation also, the tachy component is the atrial fibrillation, but the patient has underlying 6 sinus syndrome, right? Right. So here is another situation. Now, generally we talk about atrial fibrillation being a narrow complex tachycardia, right? But remember that even if a broad complex tachycardia is found, if it is irregular, that is AF. So essentially, just because it's a broad complex tachycardia, that does not mean it's always VT. Though generally, we as electrophysiologists, we always say think of broad complex tachycardia as VT. If it is irregular, it is atrial fibrillation. So here you can see, and it's probably due to either a pre-existing bundle branch block, a rate-related bundle branch block, or maybe some aberrant conduction down a WPW, something like that can happen, right? Sometimes we have what's called slow AF in this kind of situation where the ventricular rate is slow, right? This can happen, and if you look at this, sometimes if you look at some of the leads, you really can't see any fibrillatory waves in the underlying rhythm. That is because there's very little activation of the atria, right? Now this is whenever there's atrial fibrillation and slow ventricular rate, it is due to AV block. So there is some degree of AV block. That is why the rate is slow.
Okay, is that enough? The ECG is enough to diagnose AF, or do you think that there are some other things that we?
Well, if you look at the diagnosis of AF, generally, traditionally, we have been using the ECG, right? So 12-lead ECG, you can detect the 12-lead ECG. That is the kind of best way of diagnosing atrial fibrillation, right? But now we see that now we have patients on monitors in ICUs, and then we also defib patients sometimes. So sometimes monitor rhythm strips and for instance can show up atrial fibrillation. So that's another way of diagnosing atrial fibrillation in patients who may be in the ward. Then we also can diagnose atrial fibrillation using Holter monitors and event recorders, which are more long-term recorders, right? Now, the 2020 ESC classification very specifically said, this is quite an important thing, that to diagnose atrial fibrillation, you must have a rhythm which is irregular RR intervals and no discerning repeating P waves in a 12-lead ECG or a single-lead ECG, meaning that like a rhythm strip with at least 30 seconds of atrial fibrillation. That's the important point. So it's 30 seconds. We have to document that. That has 30 seconds. That's, I think, an important recommendation made.
So it's important to have a rhythm strip.
Yeah.
To diagnose.
So even if you have a rhythm strip, you must document the AF during a period of 30 seconds, which is quite a long time.
Yeah, quite a long time. Yeah, that's right. Now, are there any newer methods of detecting this condition?
Yes.
Apart from ECG?
There are now. So now these are traditional ways we have been detecting atrial fibrillation. But if you see newer methods, one thing that we have is this thing called an implantable loop recorder. Now, implantable loop recorder is like a long-term Holter recording, and this is the kind of thing that we have. And these are very small. You can see that the smaller one is actually extremely small. These are implanted under the skin in the anterior chest wall. What they do is, and these have very long-lasting batteries. Basically, the batteries last for about 2 years, right? And they continue to monitor the heart rate. So we can program these devices to detect atrial fibrillation. And this is one of the kind of gold standards for detecting atrial fibrillation in patients who are asymptomatic. Very useful again. Sometimes we have patients who are having so-called cryptogenic strokes, where we suspect that the AF might be the reason for that. And for patients like that, we actually put these devices to see whether we can detect atrial fibrillation. That's one useful thing. Then the other thing that nowadays what happens is all of us, I'm sure, have smartphones, and we are wearing all kinds of stuff, Fitbits and all kinds of smart watches as well. All these can detect atrial fibrillation. Some have actually got apps inbuilt apps which can detect various different heart rhythms. And these are now therefore we are picking up more and more patients who are having asymptomatic atrial fibrillation. Right? And the other thing is that now again we have many patients who have cardiac devices like ICDs and pacemakers, right? All these also can monitor the rhythm as well. They don't only do their job as pacing or giving shocks, but they are monitors as well. So when we regularly interrogate these devices, usually about once a year at least, and then sometimes we come across a situation like this. For instance, if this is an interrogation of a patient with a dual chamber pacemaker. The upper rhythm is the atrial rhythm, and the middle one is the ventricular rhythm. You can see that in the atrial rhythm, there's a very fast rhythm going on, right? And in the whereas when the ventricular channel is quite slow. So this is obviously atrial fibrillation. So these are another way that we can detect patients with atrial fibrillation.
How sensitive these things are? There are many things you name, but out of these things.
Yeah. So if you look at this slide, you can see that the traditional pulse taking is not bad at all. So basically, it's quite a good sensitivity, though the specificity may not be that much, mainly because there are some other rhythms other than atrial fibrillation which have irregular rhythm. For instance, if you have frequent atrial ectopics or ventricular ectopics, you might have an irregular rhythm. That's one thing. But on the one hand, just feeling the patient's pulse itself is a very good way of detecting atrial fibrillation. Then, of course, a lot of patients now have automated BP monitors, and sometimes they come and say, "Doctor, මම එදා මේ pressure බැලුවාම මගේ heart rate එක ගොඩක් වෙනස් වුණා." So that's a very common thing. I'm sure you have come across that, right? That's one thing, right? And then single EDC, we are talking about things like rhythm strips and things like that. But you can see that smartphone apps and watches have an extremely good sensitivity and specificity as well. So that's another way of, in fact, certain countries are now relying on this to kind of detect atrial fibrillation.
Oh, very good. Now see, if you detect, if you come across a patient with acute episode of atrial fibrillation, what are the things physicians should consider or, give a priority?
Right, okay. So you're talking about patient presenting the first time visit AF. Yes. So the first presentation of AF is actually a good opportunity for the physician to do certain things. First of all, of course, you must decide whether the patient needs treatment for that particular episode, because you might need to cardiovert the patient, you might have to have late control, so that's an important point to consider at that time. Other than that, right, this is a time to assess risk. Could be the risk for developing atrial fibrillation, or even the other risks which involved with making atrial fibrillation more dangerous or increase, where the morbidities increase. So that's another important thing that we should do when we come across when we have the so-called first presentation of AF. Right? Then at that time you can also try to categorize AF. Remember that might not be very easy sometimes, because when the patient comes, you don't know whether this patient is paroxysmal AF or persistent AF, whatever. Some patients are very, very clear. They say, okay, might say, okay, sir, my wife on call හිටියා. ඉතින් මම මේ පොඩ්ඩක් බිව්වා. උදේ පාන දෙකට මාගේ පපුව ගැහෙන්න. You can, there are patients like that come. Yes. So wife දන්නේ නැතුව, right? So that time you know exactly the patient got the AF at 2 o'clock in the morning. But other patients say, I was tired for a few months, I'm not physical, and then maybe can be picked up somewhere else. So in that situation, you're not very sure. This is important because when we come to deciding what to do at that point for the first presentation, we need to know when it started. Yeah. That's another important point, right? Then again, very, very important, this is the time that you must assess the patient for a stroke risk. So the patient might need anticoagulation. So this is very important to assess the risk of thromboembolism in these patients who have first presentation of AF, right? Other thing, of course, at that time, you must also be able to plan long-term management, because these are patients who are going to need management for the rest of their lives, basically.
Yeah. So with that, how are you going to manage these patients in the first episode? So what are the things physician need to know? Yeah.
So when you are managing an acute episode, there are certain things to consider, right? One thing, of course, we know that what you do initially depends on hemodynamic stability. You all know, I'm sure, how to assess the patient, whether the patient is hemodynamically stable or not. And that is important because that will decide the initial management. That's a very important thing, right? Then, of course, comorbidities have become important as well. So, for instance, if the patient has LV dysfunction, patient has ischemic heart disease with, say, critical coronary artery disease, or some kind of obstructive lesion like mitral stenosis, aortic stenosis, or something like HOCM, even patients who are relatively stable can deteriorate very fast because the very fast rhythm causes issues in these patients. So a patient with, tight mitral stenosis can go into left ventricular failure very quickly if they get fast atrial fibrillation. So the simple comorbidities are very important. Similar, and then again, as I said, you have to think of the risk of thromboembolism and stroke, because this might affect or this might change the way that you treat that particular episode. So it's important to assess that as well. Right? For instance, if we have a patient whose CHA2DS2 score is 1 or 2, we might not be too worried about thromboembolic risk in cardioverting that patient compared to a patient who has a CHA2DS2 score of 5 or 6. So that's also, I think, an important point to remember. Right? And of course, the onset of atrial fibrillation, as I said earlier, is important in a management. I think we'll come to that sometime later. So because there's a so-called safe window which is within 48 hours of the onset of stroke. So that's a kind of important, these are some of the things that we need to consider.
Yeah. If the patient comes hemodynamically unstable, in that situation you won't be doing all these things. And what is your approach?
That is true. So as I said earlier, the patient's hemodynamic state is the most important thing in deciding the initial management. If the patient is hemodynamically unstable, there is no question you have to do a DC cardioversion, because if not, patient can become bad, deteriorate, and die. Right? So at that point, you can't think of anything else. You can't worry about the thromboembolic risk or anything like that. You have to do a DC cardio. That's what we generally, it's not generally, but that is what has to be done. There's no question about it, right? When you do when you attempt a DC cardioversion in atrial fibrillation, you have to remember that one thing is that unlike for supraventricular tachycardias and ventricular tachycardias, where we start off with about 50 joules, you have to start off with at least 150 joules of biphasic current to cardiovert atrial fibrillation, particularly if the atrial fibrillation has been there for some time. So it needs quite a big shock. Right? So 150 to 200 joules, which means that you have to nicely sedate the patient with dormicum, with midazolam, and maybe even a combination of midazolam and morphine. That's the important point. Unfortunately, sometimes these patients don't get cardioverted, in which case you have to do what you call acute rate control. That's also something that you need to do. Right? If the patient is hemodynamically stable, then you have time to kind of play around, and then you can decide whether to consider rate control, rhythm control, depending on the various factors like the thromboembolic risks, what the patient's symptoms, and things like that.
Yeah. Now, considering the pharmacological cardioversion, so what are the drugs available?
Sorry, I want to mention this point. So for this 48-hour window is very important.
Yeah.
Within this 48-hour window, what we have found is that within 40 hours of the onset of a new atrial fibrillation, the risk of thromboembolism is the lowest. Right? That's important. So that is a very important point. Right? And if you look at the pharmacological, the recommendations for pharmacological cardioversion of AF, it is only recommended if the patient is hemodynamically stable after considering thromboembolic risk. So that's an important point. So, but as I said, if the patient cannot be cardioverted to sinus rhythm by DC cardioversion, you have to try other methods. So it might mean that you might have to try cardioversion. So sometimes what happens is we give a bolus of amiodarone and then try to cardiovert again. So those are the attempts that we do. But that's the kind of, so these are complicated issues of managing acute atrial fibrillation.
Yeah. So what are the other available medications, pharmacological agents,
right,
apart from amiodarone?
Yes, so in Sri Lanka at the moment we only have IV amiodarone. Right? The flecainide has been brought into the formulary. We have been requesting for a long time, but still we don't have it available. Right? I think there are a few wires here and there, but that's about it. Right? But if you look at this chart, you will see that the most efficient drug in pharmacological cardioversion of atrial fibrillation is actually flecainide. Right? It's the fastest and it's very, very effective. Right? And then, of course, we have propofenone, but propofenone is something that we probably will never get because it's very rarely used for anything else. Right? It's only for atrial fibrillation.
But it's a cheap drug, isn't it?
It is. It is not. It's not a very expensive drug.
Yeah.
But you know how it is in Sri Lanka. People try to get down expensive drug. Nobody wants to get down the cheap drugs. So that's why we run out of digoxin most of the time.
Right. Yes.
Yeah. So, but that's a very useful drug. But again, we are never going to get that, right? So we are stuck with amiodarone. With amiodarone is reasonably effective, but you can see only about 44% of the time that we can actually cardiovert atrial fibrillation within a period of 8 to 12 hours. That's a long time, right? Other thing about amiodarone is that it's reasonably it's quite toxic. I'm not talking about the side effects that of the thyroid and the various things like that. But giving amiodarone per se can be tricky. You need to give it to a large vein, if central venous line if possible, but otherwise because you can cause thrombophlebitis and thrombosis, which can be quite horrible. So it's an important point.
So when would you consider rate control? Yeah,
so rate control, as I said, failed DC cardioversion. In a hemodynamic unstable patient, we have to do rate control, right? Yeah. Or if the patient hemodynamic is stable and we think that it's unlikely that this patient is going to cardiovert to sinus rhythm. For instance, patients who have large hearts, large atria, severe LV dysfunction, LVH, who are having very long-standing atrial fibrillation, mitral valve disease, those patients very, very difficult to cardiovert to sinus rhythm by DC cardioversion. Also, if there's a high risk of thromboembolism, we don't want to cardiovert because we might cause a stroke at that point. So then we prefer to have rate control. Think about DC cardioversion electively later on. Right? Then things like perioperative and sepsis-related atrial fibrillation very often resolves after the initial, that insult is over. So we don't really need to cardiovert unless the patient is hemodynamically unstable. Right? So we don't, rate control is adequate. Right? And of course, if the patient is is presenting more than 48 hours after the onset, we can't cardiovert safely. So we need to rate control and think about elective cardioversion later.
So what are the drugs you would recommend?
Well, the standard drug that we use, so basically we are talking about beta blockers and calcium channel blockers. Of course, we can't use calcium channel, IV calcium channel blockers if the patient has LV dysfunction. And beta blockers may be a contraindicator if they have bronchial asthma, for instance. But those are true drugs that we generally use. Right.
So, do you think any of these drugs are superior to?
Not really. It's a kind of individual choice. I tend to start off with the beta blocker, and metoprolol and bisoprolol are the ones that we use, right? But calcium channel blockers are also as good. You can combine these with digoxin. Right? But remember that digoxin per se alone is not adequate to control the heart rate. You might have certain situation where the patient is having low blood pressure, and in that situation you can't give either of the beta blocker or calcium channel blocker, in which case you might have to manage just with the digoxin initially. Yeah. Right? Important point here that amiodarone is not a first-line drug for rate control, where it does not really have much effect on the IV node. Sorry.
Yeah. Is there any special indication to start digoxin?
Well, in a patient who is having heart failure, whose blood pressure is low, then that digoxin is the drug that we have to. We have no other choice. We have started digoxin.
Yeah. Is there any problem with exercise, and if you start digoxin?
Well, yeah, in the sense that that's why. So digoxin cannot be used as a standalone drug for the long-term management of atrial fibrillation or rate control, because it is useful only in reducing the resting rate. It is not helpful when the patient exercises. So you have to have a combination, either a beta blocker and digoxin or calcium channel blocker and digoxin.
Now, if you consider pharmacological cardioversion, rate control, now what is the target heart rate you would expect in
so earlier we were thinking of trying to bring down the heart rate less than resting heart rate a bit less than 80 beats per minute. But what this caused for some people went into severe bradycardia. So now it has been found that it's adequate to bring the heart rate down to less than 110 beats per minute. The initial worry was that at rates like this, there might be a tachycardiomyopathy, but it will be found that with heart rates of less than 110 beats per minute, there is no progression into tachycardiomyopathy. So it's quite safe to bring it down to adequate. That's adequate actually.
If someone wants to do cardioversion after 24 hours, beyond 24 hours. Now, what would you recommend?
Right, let's see. I think I just got cited. Yes, well, the best time to cardiovert the patient is within 24 hours of the episode. But as I said, you can cardiovert up to 48 hours if the patient is symptomatic, and if you can't, if the rate control is poor, or if there are very fluctuating rate control, and the thromboembolic risk is low. So in that situation, yes, up to 48 hours you can cardiovert, right? You must start anticoagulation with low molecular weight heparin immediately, as soon as possible, with simultaneously start something like warfarin or even one of the DOACs at that point. But they take some time to act, particularly warfarin. So, but you can. So you can do that, and that is recommended, right? Do I have another slide on that? Let me see. Yeah. So basically, so if you do that, remember that then anticoagulation is very, very important. And once we cardiovert a patient to sinus rhythm, it is important that we continue anticoagulation for at least 3 to 4 weeks, because this time soon after cardioversion is a time where the atria are very, very, very unstable, and atrial fibrillation can come back very easily. So in that situation, you might get the risk of thromboembolism again goes up. So it's very important not only to continue the anticoagulation, but to continue a drug like amiodarone for at least 3 to 2 weeks again, so that you keep the cardiac muscle stable. Yeah. That's something that we need to do.
Now, is there any mortality or morbidity benefit when you compare with rate control and...
Yeah, this is kind of age-old argument, right? With electrophysiologists saying, yes, it's good to be in sinus rhythm because we like to ablate and try to get the patient in sinus rhythm. But if you look at the studies, you can see that actually there is no difference with rate control or rhythm control when it comes to mortality and morbidity. So two large studies, this AFFIRM and the RACE study, showed that there was no difference in morbidity and mortality when it comes to rate or rhythm control. Right, and the RACE study also showed that there was no difference in quality of life as well. So there are lots of patients who are going permanent atrial fibrillation. They are fine; they don't have any problems. But then, thing is, these are large-scale studies, and they are looking at the majority of patients. Yeah. But I'm sure you have come across patients who are atrial fibrillation who are very symptomatic, who they can't tolerate the atrial fibrillation. So it becomes a very individual thing. So some patients with atrial fibrillation will benefit from sinus rhythm.
Yeah.
Yes.
And also we tend to think that when there is a sinus rhythm, when they are in sinus rhythm, that risk of thromboembolism is also...
Yes, that is also there, but that's a bit of a tricky area, right? Because if the big question that we have is, if they are in sinus rhythm, can we stop the anticoagulation? Yeah. That's a kind of question that you ask. No?
That's what I'm going to ask.
Exactly. So, but the thing is that you don't know whether the patient actually is in sinus rhythm all the time. Now, after with the advent of ablation for AF, which is now been for more than 20 years, they have done follow-up studies and found that these patients occasionally have what you call silent atrial fibrillation. So they don't have symptoms, but they can go into atrial fibrillation. So in that situation, again, there is a thromboembolic risk. So it might not be a great idea to stop anticoagulation just because we have been able to maintain, to convert to sinus rhythm.
We know that atrial fibrillation has high risk of developing strokes. And how are you going to decide which patient has a higher risk compared to the...
of thromboembolism? Yes, so remember that with whatever the type of atrial fibrillation, with this paroxysmal or persistent or permanent, the thromboembolic risk is the same. That's important. Now, we base our decision to start on oral anticoagulants entirely on the CHA2DS2VASc score because that has been well validated, and that is what is now recommended worldwide, right? Another important point is that if you're following our patient for a long time, remember that the patient's CHA2DS2VASc score may change over time. For instance, patient gets older, CHA2DS2VASc score changes. If the patient gets new diabetes mellitus, again CHA2DS2VASc score changes. So like that, so it's very important that every time you see a patient, at least once a year, you must reassess the CHA2DS2VASc score to decide whether the patient has to come to a point where the patient needs anticoagulation. So that's the important point. Then, and of course, you need to kind of think about choosing between warfarin and the newer anticoagulants, they called NOACs, now we call them DOACs or direct oral anticoagulants. And important to remember, there is absolutely no place for antiplatelets. So if you have a patient with atrial fibrillation, don't think that giving them dual antiplatelets is going to reduce the risk of thromboembolism. It does not. So it's not. It doesn't happen. Right? Just another slide. Oh yeah, okay. So you can also, if you want to talk about whether you want to start warfarin or DOACs, that is also a question. Earlier, a few years ago, there was no, the DOACs did not come into the first line treatment for as oral anticoagulants. But now it is considerably first line treatment, right? But the problem is the cost. Right? If you look at the cost, it's basically DOACs will cost a patient around 600 rupees per day. So that's quite expensive, right? But of course, there are patients who can afford, right? So so generally we don't convert our patients on who are well controlled on warfarin to DOACs just like that because of the cost factor, right? But if you have a patient who you are considering to be starting on oral anticoagulant, that may be a time to have a discussion and say, okay, this is the situation. If you can afford it, this is a good drug. Because one thing we know that DOACs are very effective. They have better bleeding profile, and of course you don't have to monitor them, and they don't interact with other drugs or things like Mellung and things like that. So that's a fact.
Yeah. Is it going to be a fixed dose for everyone, or?
Well, yes. Now, so these kind of these are just to go through other indications here. So basically, some patients who are warfarin now, who are having very labile INRs and things like that, also we might want to convert to a DOAC, right? Yes. To answer your question, Vimrasiri, where are we now? Yeah. So there are standard doses that we use. Right? Generally, for most patients, we use a standard dose that is, now if you look at the three drugs that are available in Sri Lanka, dabigatran came in first, and we have rivaroxaban and apixaban. Now we tend to use apixaban. Rivaroxaban is a single dose, once a day dose, right? But kind of we worry that the single dose, towards the end of that dosage period, the anticoagulant effect might not be that much. So therefore, the apixaban with a BD dose is kind of better, well, we think. But I don't know, there are no studies to show that. But there's a tendency, even in UK, we feel when we start, we feel apixaban better than rivaroxaban. Generally, the standard doses are these 150 milligrams BD of dabigatran, 20 milligrams daily of rivaroxaban, or 5 milligrams BD of apixaban. There are dose reductions which are recommended depending on the patient's weight and serum creatinine and various other factors. So if it's a very small patient, older patient, apixaban 2.5 BD is adequate.
Yeah. Can you elaborate a little bit more on CHADS score, because that is the most important score that, as far as anticoagulation.
No question about it. That is very important. We all must know this, right? And now it's very simple because you have these apps on your smartphones which you can download and just go and put the score in, and you can get the score, right? So essentially, in a female patient, if the score is 1, or male patient the score is 0, there is no risk. If you look at this the chart on the right lower, you see the risk is 0.6%, which is extremely low. And they don't need anticoagulation. You can give warfarin, but there's really no need. You don't have to give anything at all, right? When the score becomes more, 2 or more, and particularly when it becomes 4 or so, then the risk is significant, and they need an oral anticoagulation. This doesn't depend on the patient's age. We sometimes we worry about older patients falling and getting intracranial hemorrhage, and we don't give warfarin or we don't give DOACs. But it has been found that the risk of thromboembolism is much higher than the risk of injury or bleeding during the fall. So therefore, we must consider it in all age groups as well.
Now, as you start anticoagulation, there's a parallel risk as well.
Yeah, of bleeding.
Yeah, of bleeding.
Yeah.
So how are we going to assess that? And how are we going to...
Yeah, so essentially, if you maintain the INR between 2 and 3, if you're giving warfarin, then the risk of bleeding is significant, is very low. It's not very, very high, right? If you take the DOACs, they have much better bleeding profile, so that if you give something like rivaroxaban or apixaban, the bleeding is very, very much, the bleeding risk is very much less than using warfarin. So that's one thing that we know. Of course, some patients have a higher risk of bleeding for various other reasons. For instance, right, so that is assessed by this thing called the Hasbed score, right? So that assesses the risk of bleeding. So there are various things to consider, like uncontrolled hypertension, renal functions, the previous stroke, and etc. Various things like that. But remember that the Hasbed score is not to say that if you have a higher risk of bleeding, that we should stop the warfarin or modify warfarin or the DOACs. It just means that we must identify these risk factors and try to control the risk factors. That is what is meant. That is what the use of the Hasbed score. Okay. Not so much to say, oh, deny the patient oral anticoagulant just because the Hasbed score is on the slightly on the high side.
Not to discourage.
Sorry?
Not to discourage.
Yeah, not to discourage. Just a kind of making sure that these things are basically, because some of these are modifiable risk factors. For instance, uncontrolled hypertension, you can control the blood pressure like that. So like that, we can try to control these risk factors rather than deny the patient anticoagulants.
So one question, and often we come across as physicians, and when the patient is on anticoagulation with warfarin or whatever other things, if there is any compelling indication to start antiplatelets together, now what is your advice regarding?
Yeah, that is a very tricky area. I'll just go through a little bit, but this is kind of very complex situation. So that generally happens when a patient who is on oral anticoagulation, particularly warfarin, for say atrial fibrillation, and the patient comes with acute coronary syndrome. Yeah. Has a acute coronary syndrome. Then you have to start on some kind of antiplatelets. So you can't say, let's wait till the warfarin effect goes off. So it's not possible, right? So you have to do that. But remember that in the presence of triple therapy, that is oral anticoagulant plus dual antiplatelets, the risk of bleeding increases tenfold. So that's a significant amount. So you're very, very careful, right? And of course it depends on several. So whether you give triple therapy depends on several factors. Thromboembolic risk, for instance. If the thromboembolic risk is very high, then you don't want to stop warfarin or DOACs. Right? So therefore, you might want to continue that and then consider either giving only one antiplatelet or taking a risk and giving two antiplatelets. Right? Then you have to think of the bleeding risk, and of course, if it's a patient going through a PCI, it depends on the type of stent you put. If you put a bare metal stent, for instance, the risk of stent thrombosis is low, but if you put drug-eluting stent, then stent thrombosis can be very high, and then you have to think. Nowadays, most of the newer stents, you can actually manage with just 1 or 2, 3 months of dual antiplatelets and stop them afterwards. Then you continue with the oral anticoagulant and maybe clopidogrel, and after 1 year, you can even stop both antiplatelets.
All right, okay. Now, are there any other options to control apart from what you mentioned?
Yes, so traditionally we manage atrial fibrillation by either cardioverting or rate control, but there are other options. And one thing that I'm sure all of you hear about, we hear about, is catheter-based AF ablation. Right? That is where we go into because we know that that in most situations the AF is created by this impulses coming, or the electrical impulses discharging from the pulmonary veins. So we can actually we can isolate the pulmonary veins from the left atrium by doing a catheter ablation. It's a complex procedure, and though catheter ablation has been around for more than 20 years now, still the success rates are poor. We are talking about 60 to 70% success after a single procedure, and procedure not without complications. Okay, there can be very serious complications, right? So in Sri Lanka, I had done a few, but we don't really do AF ablation for several reasons. One thing, we don't have that typical patient with paroxysmal atrial fibrillation who may benefit, and it takes a long time. And then our cath labs we are trying to do all kinds of other arrhythmias. It's a bit difficult for us to concentrate on this. So therefore, we don't really do AF ablations here for that reason. Right? Then you can also do what you call surgical ablations. Those days, surgeons, when they opened up the atria for mitral valve surgery, used to kind of make cuts in the left atrium to try and isolate the left atrium. Now they can do a hybrid procedure where the ablation, they have ablation, it's a hook. You can ablate the atria as well. So that's something done. That's not done much, but it's something we try to promote. Right? The kind of final thing we can do is we can isolate the atria from the ventricle and we ablate the AV node by put a pacemaker. So therefore, the atrial fibrillation going on in the upper chambers, but it does not affect the ventricles. Of course, you need anticoagulant in this situation.
Yeah, with that, we are sharp on time.
Ah, yes.
Yes,
Yeah, okay.
And I don't think we can allow any questions from the audience because time is up, but I don't know whether
Can I just say some take-home messages, if I may? Right. First of all, that we must remember that the first percentage of AF is very, very important, and it's an opportunity for us to classify AF and define the risk factors also. And also very important that we have timely intervention with cardioversion depending on the presentation. And don't forget this window of opportunity, which is 48 hours. That is the time when we can actually safely cardiovert the patient. Also, we must not forget about assessing the risk factor. Sorry, I just want to mention that, yeah.
I would like to profoundly thank you on this presentation. On behalf of Sri Lanka College of Internal Medicine, I would like to thank you. Thank you very much.
Yeah, it has been a nice
for
discussion.
devoting your time and coming on to do this presentation as well as finishing on time.
Okay.
So I would like to invite the President of Sri Lanka College of Internal Medicine to hand over the token of appreciation to Dr. Rohan Gunawardena.
I'd like to thank Dr. Vimalsiri Uluwathage for excellent moderation. Thank you very much.